Good afternoon. Welcome to Grand Rounds, everyone. It is not canceled. I'm so sorry about that. What happened this morning? I had a physician off site, retired physician, but anyway, he said he never got the team's invite, and so I sent it just to him and deleted everyone else's name. But guess what? That doesn't work because then it goes as send update, and everyone gets a cancellation notice. So yeah, I was like, yeah. So anyway, I'm very sorry about that. But Dr. Pickoff did get his invite, so that's great. I do want to make a couple of quick announcements. The Western Ohio Pediatrics Society dinner that is coming up on October 15th. The start time is 6 p.m. I had pulled the information from an old flyer, but we sent out a survey over the summer to everyone regarding the Western Ohio Pediatrics Society, and the consensus was the majority of the folks wanted the dinners to start at 6 p.m. So the dinner will start on October 15th at 6 p.m. It's at Dayton Children's Hospital in the conference room C and D in the tower on the second floor, but contact me. I will give you all of the information and you RSVP through me. The other quick announcement, for November 13th, my speaker had to cancel. If anyone has a pressing or urgent grand rounds that they would be interested in presenting, we would love to have that. So please contact me and let me know. Again, that date is November 13th because I hate to have cancellations. Lastly, the session number for today, 2422. So again, for Cloud CME, 2422. If you have any problems, contact me and we'll get that straightened out. All right, I am now going to turn it over to Dr. Matson, and then we will bring on our fabulous guest speaker for today. Thanks.
All right. Hello, everyone. Today we have the pleasure of hearing from a physician that I've been lucky to work with in multiple capacities here at Dayton Children's Hospital, as she is a fellow pediatric medicine hospitalist, a palliative care consultant, and with all that expertise, a very valuable member of our ethics committee, Dr. Cheryl Kuck. Dr. Kuck worked as a primary care pediatrician for over 20 years in rural Ohio, where she developed her skills in providing care for medically complex children. She attended and consulted on pediatric patients in both the inpatient and outpatient setting before transitioning to Dayton Children's Hospital as the attending for the transitional care unit in 2017, where she provided care for patients dependent on mechanical ventilators and tracheostomies up until July of 2019. Currently, she's the director of our palliative care program and a pediatric hospitalist at Dayton Children's Hospital. Please give a warm welcome to Dr. Cheryl Kuck.
All right. Let me see. Don't you know it? My slides are mixed up here. Okay. So I'm here to talk about the allow natural death policy, as well as a few other things. We did update our policy recently, and so it is a little bit different. Let me see if this is the right one. Does this not work? Or am I pushing the wrong one? Oh, there it goes. All right, so a little background on it. It is appropriate to discuss resuscitation status with parents and patients and legal decision makers when the treatment is no longer a benefit, or the proposed ongoing treatments the burden is greater than what is the benefit. So this is talking about in the more of your decision making, not necessarily actual cardiopulmonary arrest. So there are instances when the cure may become unachievable, and the focus of the care changes to relief and comfort. In these cases, it may be appropriate and ethical to limit the treatments which are not going to resolve the patient's underlying condition and do not provide relief or comfort. So when are we going to do these? Well, to forgo or discontinue life-sustaining treatment may be ethically or appropriate when it's clear that this treatment will not benefit the patient. It is patient-centered. Exceptions to the general duty to provide life-sustaining treatment, including CPR, may occur when there is irreversible progression to imminent death, treatment is clearly ineffective or harmful. We see this a lot with our babies with those seizures that we just cannot get under control. Life will be severely shortened regardless of treatment, and the limitation or discontinuation of interventions will allow greater palliative or comfort care. Sometimes our metabolics and so forth fall into that category. Intolerable patient distress and suffering exists, which would be sustained or increased by the proposed treatment. A lot of our severe neurologic impairment, the parents finally say, stop, we're doing this to them. We're not doing it for them anymore. Oh, yep. Sorry. It doesn't seem to always work. No, there it goes. Okay, so we have, I got to push it harder, I guess. Use the arrows. Okay, that might work better. Okay, great. Because I was pushing and didn't go. All right, allow natural death is a new term for us to use here at DCH. So some of us have been using do not resuscitate for 30 years. So this is a real transition for some of us. But allow natural death actually does mean do not resuscitate. The Ohio protocol, which is what is outpatient, is actually called do not resuscitate comfort care, by the way. A lot of people don't realize that the comfort care is actually part of the protocol as well. So both of these focus on allowing and respecting a patient's choice not to have resuscitative treatment in the event of cardiopulmonary arrest. So what we're talking about is that cardiopulmonary arrest. We're not talking about what leads up to that. We're talking about that event. Allow natural death, we switch to it because it actually implies that the patient is you are going to allow your child to do something. They're going to allow them to go through their natural pathway. And for parents, that is a different emotional response than saying, I'm not going to save my child, which is what DNR is. Do not resuscitate. And just emotionally, and I'm going to mention it again, because emotionally, that is harder for parents to say, do not help my child, than it is allow them to have their natural progression. So we're going to talk a little bit about the Ohio DNR resuscitate protocol. Now, these slides are actually online. This is put out by the Department of Health, and if you go ahead and Google it, you can bring up the slides themselves. They are for the general public. They are for the general public. They are not necessarily geared towards medical people, so you may find them a little simplified, but they're very good, and this is their protocol, so I wanted to use their slides for it. So what is DNR? Do not resuscitate order allows individuals to document their choices relating to cardiopulmonary resuscitation. As an individual, you have the right to document that you do not want to receive CPR or other resuscitative orders. This is different than doing ones for it's just the CPR. It doesn't include all of your living will rights and things like that. This is just the CPR. And one of the things that is over the years I've realized is This is something that we should all be thinking about. All of you have parents, or maybe not, but you've had parents. All of you may have spouses, or you may have significant others, but you may have yourself, and you definitely have yourself. And if you don't have those discussions with the people that are close to you before something happens, and you may not know it's going to happen. Maybe it'll be a car accident. Maybe it'll be a different type of accident. COVID hit. We didn't expect for things to happen. But these are instructions. They're not orders, they're instructions. So if you don't communicate that to people about yourself, they may not know, and your wishes and desires may never happen. So these are about cardiopulmonary arrest. It's not about whether or not I want this done or that done. It's cardiopulmonary arrest. And those are decisions that can be made now for something that may happen in 10, 15, 25 years from now. But you need to talk to people. So I encourage people to actually think about, while I'm talking about it, think about yourself. What do you want? So what is CPR? CPR is cardiopulmonary resuscitation, includes the administration of, and we pretty much know these, administration of chest compressions, the insertion of an artificial airway, administration of the resuscitative drugs, defibrillation or cardioversion, provision of respiratory assistance, initiation of resuscitative IV line, or cardiac monitoring. Now, this is the actual form that they have. One of the things that's important to know is that it is not a legal document for children. And we tell our parents that. These are instructions. They are honored by most institutions, but it is not a legal document for children. In the rules, it talks about having to be an adult. So as we go through the slides, they're going to be referring to adults, and we need to apply what we can to the children. So this is the form. As you can see, the top part, it has the patient's name. And then what's interesting is a lot of people think people have to actually sign the form. It's not, it's optional. So whether you're signing it for yourself or signing it for your child, it is optional. And to tell the truth, most parents don't sign it. Because really what this form is doing is the next line down where it says what required, that's a physician or a nurse practitioner or a PA. That is a provider signature. And what we're saying is that we agree with these parents' wishes or your own wishes, but that we agree with that it is a reasonable decision. And so it doesn't require the actual patient to sign it. Then there are two more boxes, and I'm going to talk about these two boxes, but you have a choice between DNR-CC arrest or DNR-CC. And then on below that, it talks about what providers will do, and we'll talk more about this, and what providers won't do. So who can obtain a DNR? Any individual. That's why I mentioned, personally, you personally can do this as well. They can have a DNR form completed. You do not have to have a terminal illness. You do not have to have a life-threatening condition. You don't have to have a life-shortening condition. Completion of a DNR form will allow you to have choices regarding CPR honored across the spectrum of healthcare providers. So where can you get the form? If you go online under the state of Ohio, this is their website. It's ODH, is Ohio Department of Health, Ohio government. And actually, if you just put in their resuscitative DNR order form, it will pop up. Okay. So who can complete the order form? A DNR can be completed by a physician, an advanced practice registered nurse, or a physician's assistant, as long as it has your consent. These providers will be referred to as authorized healthcare providers throughout the PowerPoint. So Ohio has two types, and this is different from state to state. A lot of states use MULS and PULSE and things like that. This is a little bit more unique, Ohio's. So we have two types of DNR. You have DNR comfort care, or you have DNR comfort care arrest. So the difference between the two isn't the actual protocol. It's when the actions of the protocol are instituted. So it's a timing, not the actual procedures that are different. So you have DNRCC. What DNRCC is it's effective as soon as the authorized healthcare provider has signed the form. As I said, it's us signing it. It's not the patient or the parents that are signing it. So this means that as soon as the form is signed, you will not receive any treatments listed in the will not category. You will continue to receive treatments in the will category. So the will not is going to include things like recitative medications, CPR, ventilator care, continuous cardiac monitoring, or defibrillation. The DNRCC arrest, it's still going to do the same things. As I said, the protocol is the same, but it's not initiated immediately. It's initiated when the patient starts to have cardiopulmonary arrest. So it's very well named. So the arrest does not become effective until you experience cardiac or respiratory arrest. Up until the time you experience a cardiac or respiratory arrest, you will receive all the medical care necessary to treat any illness or injury, including intubation. And a lot of times people think, oh no, you have a DNR, you can't be intubated. That's not true, especially if we have a DNR CC arrest. So you'll be treated as any other medical patient. Should you experience cardiac or respiratory arrest during that treatment, at that time, the DNR protocol would become initiated and they would not start resuscitative measures. So the DNR protocol, what will they do? They will, and this is still all outpatient. We haven't started to talk about inpatient yet. This is outpatient. They will conduct an initial assessment. They will perform basic medical care. They will clear airway of obstruction and suction. If necessary, for the comfort of the patient, they will give oxygen and CPAP or BiPAP. If necessary, again, for the comfort of the patient, you can get an IV and you can give hydration or pain medications. And if possible, they can go ahead and contact any other appropriate person on your medical team. So what won't they do? They will not perform CPR. They will not insert an artificial airway, intubation, ventilator, that sort of thing. They will not administer medications with the intent of restarting your heart or your breathing. They will not defibrillate. They will not cardiovert. They will not initiate pacing. They will not initiate continuous cardiac monitoring. And actually with our patients, a lot of them are already on CR, that are getting this are already on CR monitors. You're not taking them off. You're just not initiating once. So what does prolonging death mean? For the purpose of DNR, prolonging death means providing care with the intent of keeping that person alive, as opposed to giving the purpose of comfort care. Yes.
Let's ask the question. For the will and will not list, sometimes I modify the list. Is that allowed?
No, you cannot modify it. It makes it invalid. But with children, it's not legal document anyways. So, but you can't change. You cannot make any changes. And for the adults, it invalidates it.
Even if the changes are signed.
Even if they're signed, it invalidates it. There was a slide on that and I took it out. I guess I should have left it in. But yeah, it invalidates it. So can you receive other health care when you have a DNR? Yes. And this again is a lot of confusion for people. DNR does not mean do not treat. You can and should receive the medical care that you require in the event of an illness and an injury. The DNR solely pertains to cardiopulmonary arrest. It's just that event that you're referring to, does not address and is not limited by other conditions. So how can I ensure sorry, that was that one. Does not mean do not treat. Okay, how can I ensure providers know I have a DNR? There are actually many ways. Here we use just the paper form, but in all actuality, there's a bracelet and a necklace and a wallet card that can be used. Our kids don't carry wallets. The paper, I usually suggest to people who have young enough children that they put it in the diaper bag. If they're a ventilator child, put it in your go bag, but put it into some place that you know that you can access, because you could be out at the fairgrounds and something starts to happen. You want to have it with you is the idea. Don't leave it at home in a safe that you can't get to. So what happens if I become ill or injured? So if you experience an illness or an injury that is treatable, it should be treated. So some examples of the common conditions, and again, we were talking about adults with, this is geared more towards adults, but if you have a urinary tract infection, and kids get those too, the Heimlich maneuver for choking. If you get a fracture, influenza, bleeding, uncontrolled pain, or dehydration, those are all things that, yes, we should be treating those things. They're reversible, easily reversible. So what if I change my mind and no longer want the DNR? You can revoke your own DNR at any time, either verbally or by destroying the DNR form, or permanently removing, as I said, they have bracelets and so forth for the adults, permanently removing those. That is the truth for inpatient as well, with your allow natural death orders. If a parent is in the room and you have an A&D and they say, wait a minute, I changed my mind, we start resuscitating, because that's all they have to say, is that they've changed their mind. They want you to resuscitate their child, and we will be responsive to that.
Does that work the same with adults?
Yes. As long as you have you have to be like a healthcare proxy, because if he's getting CPR, chances are they're not making their own decisions. So you would have to have healthcare proxy. If a facility is discharging a patient, and this is sometimes confusing for people as well. If a facility is discharging a patient with the outpatient DNR, which is the Ohio protocol paper, to another facility, they are required to notify, and this is true for us, as I said, because we honor it, we do this as well. So we're required to notify the receiving facility of the DNR status, and we have to send a copy of a new form. So don't reuse the old forms for this particular thing, use a new form. And that would imply that you would head a discussion, because the most important thing about all of this is that you have the discussions with the family. So that would imply that you would head a discussion with the family that they want to continue the DNR as you get transferred to a different facility. So the facility we must also notify the transportation provider. So whoever's taking that child, whether it's our own squad or one that we've hired, they need to be notified as to what the DNR status is, or code status. So one scenario, yes.
So I'm unclear about family.
Uh-huh.
They aspects bring back on
If it's beyond the expected of what you can do medically, I can't say that I have seen any actual literature on that, but I would expect at that point, you would explain that medically, that is not a possibility any longer. If they change their mind though, and you are still doing chest compressions, or you still are, you still have a heart rate, you can start your chest compressions. Yep. So this particular scenario is one actually that we certainly have seen in our own patients. So I thought it was a great one for an example. Is they had a DNR form. So you have a DNR form signed by your doctor, and that you've chosen DNRCC arrest. You develop a pneumonia, and the doctors at the hospital determine that a short period of time on a ventilator is necessary as part of your care. So is this allowed? Yes. Based on your DNRCC arrest, you can still be provided ventilator care as part of your treatment for your condition until such time as you experience cardiac or pulmonary arrest. Once you experience the cardiac or pulmonary arrest, then those resuscitative interventions would stop. You would be removed from the ventilator and provided comfort care. And that would include all the medication. You wouldn't get the resuscitative medications and that sort of thing, but you would certainly get your comfort care medications. If there's agitation, you may be giving Ativan, that sort of thing. Now, as I said, we've seen this. I had a patient that had a DNRCCA and got RSV. And so she came in, and we felt that she had a real good chance of surviving if we could get her on the ventilator. So we put her on the ventilator. She came off maybe 3 or 4 days later and continued to go on and be discharged. That was perfectly allowable because she had a DNRCC arrest. And to tell the truth, I do a lot more DNRCC arrests than I do DNRCCs. It gives the parents the comfort of knowing that their child is not going to go through a long, drawn out code, which they don't want for their child, but it does allow them to treat their child as invasively as they want to do it. So that is probably the more common way that I do it. So the allow natural death, let's talk about that as far as our policy and our order forms. So especially for you residents, this is what the order looks like when you put in and is allow natural death. You have a choice. You can allow natural death or you can do a modified. So say you choose the first one, allow natural death. Then you're going to fill out the name of the parent, the witness to the discussion, because you should have had a discussion, and the name of the provider who had the discussion. It also mentions that the attending physician or AAP must be present for the initial discussion, not the follow-up ones. So if somebody has an outpatient one and they're getting admitted, that is a follow-up discussion, and the residents certainly are capable of doing that. So that is it for an allow natural death, no resuscitative efforts. So then if you don't check the allow, you check the modified, allow natural death, you're going to come up, and the first thing it's going to say is non-invasive respiratory support. You notice there's no. If you're going to choose resuscitation, you're going to at least choose non-invasive resuscitate support. So there is only the choice of yes there. And then there's the same information afterwards. That's on everyone. So if once you hit the yes, it's going to bring up, do you want invasive respiratory support? Intubation, mechanical ventilation, non-invasive must be chosen because it's not going to even pop up until you choose it. So then you can choose yes or no for whether or not they want that. So say they say yes, Then it pops up with cardiac support. Do you want to or do you not want cardiac support? It's just the 3 tiers there. There's no long list. What we, whether we're going to do blood pressure meds, whether or not we're going to do hyperal, which really doesn't have anything to do with cardiopulmonary arrest. This is closer to what PALS talks about. It follows PALS. So you say no. So this patient would be able to be intubated and have respiratory support. But if the heart rate goes down, you're not going to start CPR. You're not going to shock them. You're going to let them continue along their path at that point. So if you said no to the invasive, it's going to automatically come up with the default of no cardiac. If you're not going to do the invasive respiratory, you're not going to do the invasive cardiac. Can it be overridden? Yes, it can. There are a few circumstances for a few kids that you might want to override it. So it can be overridden, but that is the default, is no, no. So this person is basically going to get non-invasive, and this is basically an allow natural death at this point. If they say yes to both of these, they say, yes, I want respiratory support, and yes, I want cardiac support. That is basically a full code. You've had the discussion. The parents have told you that you want a full code. Please put in the full code order. There is an order for it. It will come up then on the storyboard, full code. That means that will travel with the patient when they get out of the ICU and go to the floor or whatever. It's going to travel with the patient that you've had a discussion with these parents, that you know that they want them to be full code. So those are the orders. Any questions on that real quick? Yes?
Okay, so you're giving great examples of when people say like change the line at the bedside, then at the bedside, and so forth. What about the patients that are wards of CSB where there might not be a person in the room? There might be either a biological parent or a foster parent that is caring for the child, but the person who
Only a legal guardian. And if CSB is the legal guardian, you need to get a hold of CSB. And there should be somebody on call 24/7 for CSB. So some changes that we made. In the old policy, it referred to the decision to forego cardiopulmonary measures as do not resuscitate. Now on the inpatient, we will be using the allow natural death, and the outpatient will continue to use DNR because that's the Ohio Health form. We're not changing Ohio Health. So the allow natural death, as I said before, is preferred because it's a positive statement. For parents, it's a lot less distressing to ask them if you would like your child to have a natural death than it is, do you want us to hold back saving your child? And so it's just a lot easier on them emotionally. Talking real quick about assent and consent, as this is in our policy as well. Assent means to agree to something based on freedom of choice and based on the understanding of the matter. In healthcare, assent gives minor patients the opportunity to participate in decisions regarding their care to a degree which is appropriate for their stage cognitive and emotional development. It doesn't give an exact age. This is not the legal consent of 18. So it's going to change with their development. Some hospitals like CHOP says 7. There are other hospitals that say 5 to 7. Some of them say 8. There is no actual age associated with it, but there are criteria that they should be able to do. So to incent, it means you should be helping the patient achieve a developmentally appropriate awareness of his or her condition. Telling the patient what he or she can expect from tests and treatments. Making a clinical assessment of the patient's understanding of the situation and the factors influencing how he or she is responding. And this is a real important one. Soliciting an expression of the patient's willingness to accept the proposed treatment when possible. And this is the important part. If the patient will receive the treatment despite his objections, the patient should not be led to think that refusal of the treatment is an option and should not, in fact, be asked to assent. So that 7-year-old that you're going to draw blood on, if you are going to draw the blood no matter what, don't say, is it okay if I draw your blood? Because when he says no, what are you going to do? And if you need to say something, you could give him a choice. Do you want the right arm or the left arm? Because that's a choice you can go with. But don't ask them to do, to assent to something that you're not willing to not do.
How does
Consent.
this work in a situation with a cancer patient that's like 17, that's fully aware, alert, and oriented, that disagrees with doing treatment, but the parents want to continue treatment?
Well, unfortunately, they're not of the legal age to consent. So then you're working with, they are a wonderful age for assent. And that's when you start to sit down and say, hey, we're on 2 different pages here. Let's see if we can get the family on the same page. And it would lead to a discussion. But to legally agree to consent, to legally agree to something after information about risk and benefits are given and understood, the patient must be competent, which means they refer patients legally qualified to make decisions about their own care, and they have to have capacity. And that's sometimes the harder one to understand is capacity. Capacity refers to the ability to understand and reason about one's own care and includes the following abilities. They must be able to appreciate the significant characteristics of one's conditions. They must be able to appreciate the present and future. And sometimes teenagers have a hard time with that future impact of treatment options. They have to be able to judge the relationship of treatment options with their own beliefs and values. They should be able to reason and deliberate about their choice. And they must be able to communicate a decision in a meaningful manner. They must be able to assent, to tell us that this is what they want. So that's what capacity is. And a couple of years ago, we had to actually bring in, Dayton Children hired a person to evaluate one of our patients because we weren't sure that he fulfilled both the competency and the capacity now that he was 18. Most of us were a little shocked when it came out and said yes, that he did have capacity. So it can be a chore to even figure it. It's not necessarily an easy thing to know. You may need to get some expert opinion as to what kids are actually able to do and not cognitively and developmentally. So the new policy also talks about scope and responsibility. The managing physician, which is actually a new term, or the advanced practice provider, which includes our nurse practitioners, and that's new as well, is responsible for initiating the discussion with the patient as appropriate, and the legal decision maker regarding prognosis, goals of care, comfort measures, resuscitation, and medical surgical interventions, or forgoing those interventions. So that discussion needs to be with a managing physician or an APP. Okay? When possible, the discussion should be facilitated by members of the healthcare team who have an ongoing relationship with patients and legal decision makers. So sometimes that may be getting in the person who's actually not on that week for their service because they have never met that person, but they may have a relationship with the gastroenterologist or the pulmonologist or that person. They may have had a long relationship. If you can get that person in there, which you can't always, but you can at least entertain the idea that that is a better discussion if it is with people that they know. The discussion needs to be witnessed, and it can be witnessed by a resident, a fellow, APP, nurse, attending, basically any of the other medical people on the team. Then you have what we all love, documentation. So a note signed by the attending or the APP is to be entered following this discussion. This is talking about this initial discussion. And agreement about the foregoing life-sustaining interventions, whether or not they choose to do it or not to do it. It needs a note. Subsequent notes should continue to affirm or modify parents or legal guardians' decisions. So that's on your daily progress note. If you've had this discussion, then that needs, just like your FEN or any of those respiratory, there should be code status, and it should be noted what their code status is in your daily progress note. Updated orders. So the orders can be done by residents. That initial discussion needs to have a managing physician or APP, but the orders can be put in by residents, attendings, APPs, anybody who's capable of putting the order in. That can be done by anyone. The new A&D order is to be placed at the time of each admission. So as I said, they get discharged with their DNRCC, their Ohio protocol, they're getting readmitted. Every time they come back in, they need to have a new order placed. And unfortunately, there have been times that we have missed that. I can think of one of my patients that actually went down to, it was CT or MRI, but went down to imaging. And she had been multiple admissions with a modified DNR at that time. And unfortunately, the order didn't get put in, and she coded down there, and she was coded, and the parents were rather upset because they had a DNR. And that's because we didn't get the order in, so no one else knew. Those orders are important communication to the rest of the team, to the rest of the hospital. So thankfully, people told me, well, the parents didn't care. Yes, they did. They told me all about it. They did care, but they were not the type people that were going to throw a fit. So discharge documentation. So if the patient so you're going to need to have a discussion with them. Do you on discharge want to continue? Because the DNR is a little different than the allow natural death. Do you want a Ohio protocol DNRCC? You need to have that discussion. As I said, this is a lot about discussions. So if the patient is going to have that designation outpatient, an Ohio DNRCC or CCA form should be completed and sent with the patient upon discharge and documented in the medical record. Matter of fact, a copy of it should be given so that it goes into the media section. So a copy is given to the people at the desk that have the paper chart, and then it will be copied into the medical record. If home health is involved, the patient has to have a new form each time. And the reason why is because home health cancels out all of their orders as soon as they're admitted. So they won't have that as an order unless you do that paperwork again. So if they have a home health, they have to have a new paper. If home health is not involved, then the previous Ohio DNR form can be used as long as you've had a discussion. Do they want to continue it? Don't assume it. You need to have that discussion. Things may have changed during this admission. So you need to have the discussion, and then you need to document in the chart that you had the discussion and what the discussion came up as what the parents' wishes were. If they're to be transferred, and I mentioned this earlier because it is in the Ohio protocol, If the patient is to be transferred to another hospital or institution, an Ohio DNR form is to be filled out and sent with that patient at that time. Then we get to one of the special things, which is anesthesia, because I think sometimes there's a lot of question about the anesthesia. And it is a little bit different than some of the others. So in the event that a patient requires general anesthesia or procedural sedation, the perioperative team, the attending, which is the attending anesthesiologist or an attending surgeon, will discuss with that. So they will do the discussion with that adult patient or their legal guardian or the legal guardian of a minor patient or the parents, what their wishes are, whether they want to continue, modify, or suspend the A&D or DNR, because it could be an outpatient surgery, order during the perioperative period. So they are to have a discussion and they need to document it, that they've had the discussion. The perioperative team should document such discussion, what the patient's wishes are, and it should be placed in the medical record. In the event that a patient with an A&D, and this is sometimes a little confusing for people, but in the event that a patient with an A&D or a DNR order needs emergency surgery and a legal guardian or representative cannot be reached, so when you can't get CSB, the healthcare team, including a surgeon, an anesthesiologist, and hopefully an attending, but they may not be present at that time, could be in the middle of the night and the attending isn't there. But if available, they may temporarily suspend the A&D or DNR order during the perioperative period. So that's a little bit different than, because up until now it's been respect it, but there are times when it actually can be lifted, and that's one of the times in an emergency surgery. Then the team can get together and say, yes, we need to do this surgery. There is more in the policy. I won't say that that is everything, but I think those are the highlights that you need to know. It can be very confusing, and I certainly understand that because it is a lot of legal sort of things as well as just procedural. Certainly, if you want me to come and re-talk to people at any time, I'm glad to do that because there's a lot here. There was a lot to get into, a 50-minute sort of presentation. Any questions? Yes.
That initial conversation has to happen by the
No, just the very first one. What it comes down to is, I don't want to say patient experience, but it is good medical care for them to have an attending for that initial. This is probably going to be the biggest decision that these parents ever make. And they have the right to be having the person whose name's at the top of the chart be part of that. Hopefully they have a relationship with them. Sometimes they don't. It's a typical kid who was in a car accident. They wind up in the PICU. They don't know any of us. But at that point, we still feel that it is best to have that initial discussion and attending there. Or in the NICU, it may be a nurse practitioner that would more commonly be there, especially at nighttime, because the attendings just aren't there at nighttime. We tried to reflect what we do as well in this, not necessarily telling everybody to change anything. We tried to reflect what we do, but keep it valid. Yeah, Mike.
Cheryl, that was wonderful. This is a topic that really we don't talk about enough. And it's probably something we don't reach enough in our own minds, much less with some families. For people who do this the first times you do this, or I always draw on my experiences of when I've seen this done poorly.
I think,
Otherwise,
oh,
they can't
sure.
hear.
Yeah, thanks. I think one of the worst ways I've seen
and I don't say limitations of care, I say limitations of medical interventions or LMI. And I think taking the word care out of that picture, talking about limiting care, that always has left a bad taste in my mouth personally. But I think one of the worst ways that I've seen this presented to families when you have this conversation is with a list. Do you want shocks? Do you want compressions? Do you want meds? Do you want bagging? Do you want, and I think you don't need a physician to go through a list like that with a family, right? You could show somebody a checklist. And I akin this to when you go, if your car's making a rattle, if the mechanic went down a list and said, do you want me to change your CV boots? Do you want me to resurface your rotors? Do you want me to change your differential fluid? And you're looking at them like, just fix it. What's your expertise? What's your recommendation? And so when I present things to families, I do that within the scope of what do I think would benefit that child, and trying to align that in a conversation with what the family wants. I think it's a huge disservice personally to go through and talk about each and every individual things. And when I get some families that say, you can shock, but no compressions, or vice versa, I instantly know how it was presented to them originally. And that's a big disservice. So I talk to them about, how aggressive of medical interventions would you want? Are we doing something to your child? As long as it's doing something for them, I think that's okay. But, having that conversation organically, and then checking those things off on the paperwork that we have to do, things that I feel are in line with what the family wants. And I clarify that with them, but I think that's an important thing to do, and a disservice to do otherwise sometimes. So.
And that was actually what drove a lot of the change to the new order, where you basically have respiratory and cardiac, which follows PALS, but also asking the parents every single time their child gets admitted, do you want this? Do you want that? There were 13 questions that we had to ask them. And that is hard on parents. It's just like when we're rounding, parents have told me over the years that they don't need to hear the laundry list of what's wrong with their child. They know what's wrong with their child. And although you may be presenting it to the team who may not know, the parents are there. They do not need to hear that entire list of everything that's wrong with their child. And they have complained. But it's the same thing. You're asking them to go through a list of things that they didn't even have the experience to necessarily know what you were asking them. Hyper-L, I don't know what's Hyper-L, sort of thing. So it was a good change.
All right,
But it is confusing.
The next question is from Melanie Jungblut. First off, compliment. This has been a powerful and helpful presentation. And then her question is, do you ever get primary pediatricians as part of these discussions?
Certainly they can. They can have the discussion. Actually, I have patients that it's their primary care that has done the entire discussion. So certainly that sort of communication, I'm a palliative care doc. We love communication. We're kind of big on that. That sort of communication would be really valued, and something that we should probably consider more frequently.
And I believe Alicia Link from the online audience may have a question. She tried to unmute a couple of times. Alicia, do you have a question? All right, I guess not. Any other questions in the audience? Got one back here.
Thank you, Dr. Kuck. That was really great, grand rounds. I do have a question relating to health equity and culture differences. Do you ever come up against something with, cultures that a family has and their beliefs or whatnot? I mean, I would think that could probably be quite challenging.
Yes, we come up with it all the time. We just had a care conference on one yesterday, because the child is a DNR. And if the child loses his Broviac, which when he got transferred up here from Cincinnati, he only had a PICC line, and they said that as soon as the PICC line was done, that we would allow a natural death to happen because we could not get another line. We were fortunate enough for things to change, and we got the Broviac in. But if he loses the Broviac, would he at that point just be allowed to pass? The mother's religion doesn't allow you to stop feeding the child. So yes, we will make an effort to feed that child because her religion does require that. That's a cultural thing. So very definitely we see culturals. That a child that I spoke to before did pass, the one that had the CPR that they were not intended to get, that child did pass after a couple more admissions. They had a very Christian background and were very comfortable. We extubated that child, I think 3 times, and she had survived all 3 times. When we didn't think that she would survive, but we respected their faith, and they would take her back home. She did pass at home. And just on a side note, they were convinced that they had followed their faith, because at the time that she actually died, the mom was at her OB finding out she was pregnant with another child. So it was a pretty cool time for the family.
Dr. Kuck, I came in a little late, so I really apologize if you addressed this, but I'm wondering when or with which patients we should be thinking about addressing this conversation, because I know in the adult world, a lot of times hospitals will address it with every single patient who walks through the door.
If we're
That does
talking
not seem
about
appropriate.
just the cardiopulmonary, because what I did say was you should all think about whether or not you want CPR done, because that can be done now. You don't need to have anything, any life limiting or any conditions to fill out an Ohio DNR protocol. But for what we were doing here is anytime that basically treatment is going to be either harmful or create more suffering, or is just not going to work. And we know it's that at that point, it's futile, that we can continue. We've done all the seizure meds, we've done the keto diet, we've done all those things, and we don't have anything less in our arsenal to help your child. Or you feel that that intervention will cause more harm. As Dr. Vish said, when you start doing things to a child instead of for a child. And I would say that that is the best question to ask yourself. It's the one that I present to parents most frequently. Are we doing this to them, or are we doing it for them? Does that help? Okay. Got another one?
Yeah, they're hiding behind this post.
Oh, okay.
So when you're talking about the allow natural death, no resuscitative efforts, does that include any non-invasive respiratory support? So like, can you give those patients oxygen, or is that completely out?
Line, if we went back, that first line says non-invasive.
Right.
First of all, the top line says, in the event of imminent or ongoing cardiopulmonary arrest. So this is not going to be for just, somebody coming in because they have RSV sort of thing. But if that starts to happen, then non-invasive has to be checked. There's no other choice. There is no to non-invasive.
But that was under,
because that's part of comfort care.
okay. But that was under the and resuscitation, but on the no resuscitative effort, the very top line.
Right, the very top line, you would then you can order any of the comfort care orders that you want. If you want Ativan, if you want, oxygen increased or whatever, you can do any of your comfort care orders. But what it was is, in order to choose non-invasive, you have to already have said yes. I'm sorry, in order to choose invasive, you have to be saying yes to non-invasive. You're not going to do invasive pulmonary without doing the first things first, which is your non-invasive. So that's why it's there, and you can't say no to it.
All right, there is one last question. Can we get copies of the slides? I know you can always get access to the recording. Whether or not the slides are going to be made available is up to the speaker. So I will follow up on that and let you know. Thanks everybody for your participation.
That's good for the phone.
Okay, so I got it.
You've seen me.
I was like, you should let me get that. So it was the same gal that asked the question earlier, Melanie Jungblood, would like a copy of the slides if you're
Oh, I
willing to
know
do that.
Melanie.
So
Yeah.
I wouldn't mind a copy of those
It's
slides.